Well, good evening, everyone. We're just going to wait a few more moments to allow a couple of other people to join, and then we will kick this webinar off. Well, it's with great delight that I welcome you all to this ATS PAT joint webinar on the global perspectives of COVID-19. I am Richard van Zyl-Smits. I'm one of the co-moderators for this evening. I'm a pulmonologist and intensive care specialist based at the University of Cape Town Lung Institute and Thoracic Hospital. And I'm joined this evening with by my co-moderators and chairs of the International Health Committee of the ATS, Dr. Samia Nasser and Dr. David Lewinson. Dr. Nasser is a professor of pediatrics and director of the Cystic Fibrosis Medical Center at the University of Michigan. And Dr. Lewinson is a professor of pulmonary and critical care medicine at Oregon Health and Science University. David, I hand over to you.
Thank you, Richard. I would like to really thank the Pan-African Thoracic Society for their collaboration and contribution to this webinar, as well as our distinguished panel of international speakers providing their insights into the COVID-19 pandemic. The aim of the International Health Committee in hosting the Global Perspectives on COVID-19 webinar series is to allow respiratory health professionals in different regions to share their experiences with COVID-19 to date, and to have an opportunity to ask questions to their colleagues in other regions. This webinar will include practitioners and professors from Kenya, Nigeria, South Africa, and the United States. But before we begin, I have a few brief notes and reminders. First, due to the large number of registrants, we have muted all of the participant lines. Second, please feel free to send in questions in the questions box. We will be monitoring questions and will do our best to address these during the webinar. At the end of the webinar, we hope all of you will complete a brief feedback evaluation to help us with future planning. Please note that a recording of this webinar will be made available by email to all registrants and posted on the ATS website. So with that, I'd like to introduce our first speaker, Dr. Luce Achieng, who's an infectious disease specialist and head of the infectious disease unit at the University of Nairobi.
Many thanks for that introduction and for inviting me to give this talk. I hope you can hear me okay. You can hear me well?
Yes.
Okay, just 1 second. I'm trying to get my slides to show on the main screen. Okay. All right, so we were asked to speak briefly about the epidemiology at country level and clinical impact in the country, as well as some of the barriers and opportunities to COVID response. And my talk will really be around these areas. So first to start on the epidemiology. All right, so we've had now just about 2,340 cases in the country. So our first case came on the 13th of March. Around that time, there were a lot of measures that were immediately put in place by the government, including closing all areas of public gathering. This involved school closures. A curfew was also instituted to reduce the amount of movement, as well as reduce the public gatherings in the evening. Churches and other public events such as funerals and weddings were also restricted at that time. A few weeks later, we noted quite a number of cases in some of the areas of Kenya, such as Nairobi and a coastal town of Mombasa. And certain travel restrictions also instituted at that time to reduce travel from those two areas to the rest of the country. And the point was really to reduce any transmission to the rest of the counties. And these measures were held in place till about the 26th of April, when there was a declaration to reopen restaurants with certain restrictions. All these restrictions having been in place, we've continued to see a steady increase that has gone up, particularly over the last few weeks. The green line here represents those that have been discharged from hospital, and the red line there represents the mortalities. If you look at the regions of the country, so Nairobi, which is the capital of the country, is around there, has seen the largest number of
Sorry,
cases.
Lois, can I just interrupt you? Your slides are not advancing. We're still stuck on the first one.
You can't, they're not advancing at all?
No.
And if you could make them full screen, that would be helpful.
Right. Can you make it a
They're
slideshow?
I'm on slideshow.
Oh, no.
It's not moving at all. You still can't see.
That'll
We're now
work.
seeing different slides.
That'll work. Thanks.
Okay.
Keep going.
So, I was on slideshow. I'm not sure whether I'm. So are you able to see the next slide?
Now it seems perfect.
Mhm.
Just try moving a slide. Perfect.
Yeah.
Okay.
Okay.
That's good.
My apologies for that. So I don't know if you got to see this slide on basically the number of cases and some of the measures that have been instituted. So this slide shows the different regions of the country. So Nairobi, which is the capital of the country, has had the highest number of cases. Most of the initial cases we saw were in returning travelers. However, over the last month or so, we've seen this more in the informal settlements of the city. The other county that has been largely affected is the coastal county of Mombasa, which again, initially we saw in returning travelers and hotel workers, but now is really in the informal settlements and in the community with established community transmission. There are certain counties that continue to remain at high risk, and these are the border counties. So we have counties that border Tanzania to the south. So Kwale, Kajiado, and Migori counties have had a number of imported cases from Tanzania, and with some of those cases already establishing some community transmission. We also have counties that border Somalia. So Mandera, Wajir, and Garissa have also seen quite a number of cases, many of which have been imported either from other parts of the country, like from Mombasa or from Somalia. And with Uganda to the west, we have Busia, which also has a fairly large outbreak, with a lot of cases seen in truck drivers that go cross-country and cross a number of countries as well. So these are the number of cases we've seen, and the cases continue to go up. In terms of transmission, we've sort of done work around estimating our R0 over the period since this outbreak started. At the initial phase, it was fairly high, just about 2 or above 2, but as time has gone on, around this time we've settled at about 1.3, an R0 of about 1.3 to 1.4. And this is dynamic. As we see more and more cases, we are continuing with this plotting. In terms of what to expect, some of our modeling work has been focused on what we expect to see over the next several months, with the aim of informing some of the interventions in country. So this top chart looks at the model of an unmitigated situation. And the blue line reflects the number of ICU bed requirements, and the red line looks at mortality. So if nothing was done on the 13th of March when we got the first case, we'd have a peak of infections coming around August to September of this year. And at the peak, at the time of peak, we'd have close to about 7,000 ICU bed requirements, as well as about 1,500 deaths at that time. With the interventions that have been put in place, what we've seen is what is commonly known as a flattening of the curve. So it's sort of broader, and the peak is also pushed later. So what we have here is, again, with these current mitigations, if we maintain what we have currently, our peak would come towards early next year, with a peak of about 750 ICU cases and a mortality of just about 200. Cumulative deaths is estimated to be about 26,000 if the full interventions are maintained, a decline of about 80% from an unmitigated situation. We've also gone ahead to plot what the hospital and ICU requirements would be in different counties in the country. And this is really to help the counties prepare for what is to come. And this does not look at all patients who have COVID, but those who are sick enough to require hospitalization. And with this, you're able to tell which county is likely to have the highest number of cases. This is based on age stratification. So the counties that have the higher population of the age are likely to see more severe cases. It's based on stratification according to burden of comorbidity and population density. Working with the various counties in the country, say this is what you would expect. So in terms of preparing for isolation, this is where we should be. We've done the same with ICU requirements, just plotting some of the expected need to help the different counties prepare. In terms of clinical presentation, a lot of our diagnosis has happened in the community because of targeted testing. So we've had targeted testing of pockets such as truck drivers, contacts, as well as some of the informal settlements where we've had a lot of cases. So at the community during time of diagnosis, most people are asymptomatic, but by the time the results come and they're tracked and brought into the isolation facilities, we have about 50% who have some symptoms, majority of symptoms being very mild. In terms of looking at in detail at some of the patients we have managed in the isolation facilities, so here we have sort of entered very detailed information from point of admission to point of discharge of just about the first 265 patients, looking at what comorbidities they have, how long they stay in hospital, and what symptoms they present with. So the most common comorbidity is actually cardiovascular disease. About a third of all the patients we've seen had some comorbidity, most commonly being cardiovascular disease, diabetes at about 23%, HIV at about 12%, and the rest in reducing frequency. And quite a significant proportion of these patients are on some regular medication for chronic conditions. In terms of symptomatology, as I said, majority have symptoms at the time of admission into hospital. And I say that because our initial strategy was really to admit everybody who was positive into an isolation facility. And the aim was really to reduce contact and to avoid community spread. Of course, as our cases are going up, that's no longer tenable. And we're now thinking about community isolation or even home isolation. Unfortunately, majority of our patients come from informal settlements where large families share a single room. So that's something that we're just piloting this month, and we wait to see what the effect of that is on establishing household and community transmissions. So in terms of the symptoms you see, majority of the patients, just over 50%, present with cough. Then we have fever is also fairly common, headache, sore throat, and others again in decreasing frequency. There are some presentations, for example, we've had patients who have conjunctivitis, abdominal pain, diarrhea, 2 patients who complained about some altered taste sensation. But the most common that we've so far seen is cough, fever, the headache, and the sore throat. We've had just about around 10% of our patients presenting with more severe illness, and majority of these patients have had comorbidities, the most common being diabetes in the patients with severe illness. For the mortalities, unfortunately, we've had some mortalities that occurred in the community, and for many of them occurring very soon after admission because these patients presented fairly late. In terms of barriers and opportunities to respond, so one of the biggest issues we're struggling with is the whole issue of stigma in the community. And it's probably partly our fault because of the initial fear and that surrounded the whole issue of COVID, and how the initial suspects and patients who tested positive were handled. There'd be a rapid response team going into the communities. They'd all be dressed up in full PPE in an ambulance with a siren. So of course there was a lot of fear that was brought up. And for many of the patients, they say for them the most traumatic event around all this was how they were picked up from the community to an isolation facility. And once they get to an isolation facility, they feel like, oh, we have friendly people here, you know, it's normal, we'll just get well and go home. So this stigma is also sort of influencing testing. So many people are now scared of coming out to testing, and we've seen scenarios where a rapid response team is out in the community to do testing for community, and people just fail to show up. And I think right now one of the issues we're working on is just stigma reduction and reduction of fear. The other barrier we have is around how well prepared facilities are. If you remember the charts I showed you of how many cases counties are to expect. So every week we have a webinar with all the counties that are managing cases as a mentorship session, just to listen to some of their issues around, you know, experiences that they're getting from managing their patients. And many times they say, oh, we have a small isolation facility, and we have to keep reminding them that you're going to get hundreds of patients at any one time. You really have to think about where you will admit the sick patients, how you will isolate those who are not sick, whether at home or in a different isolation facility. Over the last 2 or so weeks, we've seen more than 100 cases, 150, 140 cases each single day. And we're already seeing an overwhelming of our healthcare facilities. So as I said earlier, our strategy has really been around isolating everyone. But it's now clear that one, it's very expensive to isolate asymptomatic people. It uses a lot of hospital resources that would be saved for other things. But at the same time, a lot of our patients are coming from informal settlements where families share a room, or several households share amenities like bathrooms and toilets. So the concerns around if you're releasing someone into a home with children, with elderly people with comorbidities, and several people are sharing a bathroom, for example, what impact will that have on community transmission? We'll probably get pushed to that corner because of the large numbers, but we're hoping that you can prepare certain facilities within the community that can offer isolation to those who can't isolate at home because of availability of proper facilities. Enforcement of mitigations is also a challenge. As you saw, we implemented a lot of mitigations and a lot of other restrictions in the beginning. But as time goes on and fatigue, the people get tired, we're beginning to see a lot more movement. Of course, there's the issue of what is the impact of all these restrictions on the economy. And people are weighing between getting COVID or getting a meal. So with that, there's a lot of pressure to open up some of these various areas and allow people to go on with their lives. The fear is that if we do that, we're moving more towards the unmitigated situation, which will even be more costly for our economy. Issues of adhering to these measures, masks are still a challenge. People are walking with masks around their chins, under their nose, on their forehead, or not wearing masks at all. And we're working on improving the communication to, public communication, to just to get people to the point of this is not a government problem. It's everybody's problem, and everybody needs to take personal responsibility for their own protection. Some of the opportunities, and I only put one here, but there have been several opportunities, is the issue of community engagement. There's been a very strong community team that's working with communities to get them to embrace the whole concept of caring for the sick at home, because that's where we are headed to. But we also have a very strong team of healthcare workers that have worked tirelessly to prepare facilities, to take care of patients, to answer questions, to talk to the press, to educate the public. And that's a resource that you cannot reward enough. I will stop there. Thank you very much.
Thank you very much, Dr. Achieng. And we'll move on to the next speaker. Our next speaker joining us from Nigeria, Professor Andrew Ohjo, and she is the director of the PATS, or Pan African Thoracic Society, NICOR, and pulmonologist at the College of Medicine at the University of Lagos. So, Dr. Ohjo, go ahead. Thank you very much.
Thank you very much, Sanya, for that introduction, and good day, everybody. It's my pleasure to be here. I'll be speaking about the global perspectives of COVID-19 in Nigeria. Um, trying to get this. Okay, sorry about that. So the current situation of COVID-19 in Nigeria is at June 1st, we hit the 10,000 number mark. And as you can see, the trajectory is what is very interesting with regards to the cases in Nigeria. We started off February 27 with one case imported, and over the next 2 weeks, the second case was discovered, and then in came the lockdown. The lockdown came about March, towards the end of March and April, and the cases remained fairly stable. But as the cases were rising, the lockdown was eased. And you can see that from May 4th, when the lockdown was eased, there was an exponential growth in the number of cases. But if you look at this, we'll say, wow, what happened? Was it the relaxation of the lockdown? But this trajectory also follows the testing. Testing improved rapidly from about 18,000 towards the end of April to about 70,000 today in June. And despite the fact that this is still a low number compared to the Nigerian population of about 200 million, but that is the main reason why we had this exponential rise. Considering the fact that 16% of all cases, all tests come out positive. So the picture in Nigeria really is that as the testing is increasing, the cases are actually increasing. The age that is most affected are those between 31 and 50 years old, and the male to female ratio is about 2 to 1. The testing policy in Nigeria is still within the zone of symptoms and key groups. So those who have symptoms and who are in certain groups, either a contact of a known case or somebody, a healthcare worker, those are the ones who are readily tested. So testing is still a challenge in Africa, in Nigeria, and that is, I think, the numbers we have is as a result of the number of tests that have been conducted. If we look at the number of total tests for each confirmed case, you can see that Nigeria has the lowest number. You only need to perform 6.5 tests to get a positive case, which really means we are screening those who are really symptomatic, and a lot of asymptomatic cases are not being screened. And if we talk about the cases in Nigeria, we look at the whole of Nigeria, but the main burden is actually in Lagos. Lagos has over 5,000 cases. Over half of the cases of COVID-19 in Nigeria is in one city of Lagos. And this is the most cosmopolitan, densely populated city in Nigeria. And this is where we had the first case. This is followed closely by the next densely populated state in Nigeria, which is Kano, and then the Federal Capital Territory. So we can see a clear pattern with regards to population and the density of the population, and is now distributed across all states in Nigeria. With the effort at the African response to COVID-19 was that of suppression. Lockdown was instituted early, but we're looking at the curves. What is happening? Are we really flattening the curve or bending the curve? If you look at the data from the United States, they appear to have flattened the curve. Europe has clearly bent their curve, but in Africa, and these are West African countries, including Nigeria, it appears to be all over the place. In Nigeria, it appears we've been flat for a while, but we appear now to be peaking. Other countries such as Guinea, Gabon, Guinea-Bissau have already gone high up in their numbers. Ghana has maintained a flat curve, and Ghana has the most tests per million population. Ghana has conducted over 200,000 tests, and yet they just have 7,000 cases. Niger is the only country that appears to be bringing down their curve. Case fatality rate is something I think we should talk about regarding Nigeria and other West African countries. If you look here, you see that the median age in Nigeria and most African countries is about 20 years. And yet the case fatality rate is similar to what we have in Germany, that has a median age, or Greece, where the median age is about 40 to 45. It means that the young African population is truly not helping us with regards to fatality from COVID-19. You can see Sudan, Liberia has a case fatality rate of over 10%. So there is a problem. And as WHO predicted that the COVID-19 will hit Africa hard, perhaps that is going to be the case. And that was the reason why we went for suppression early, but it appears not to be working. Again, if you look at the case fatality across Nigeria, it's also unevenly distributed. Lagos, that has the highest number of cases, has the lowest case fatality. And states in the northern part of the country have the highest case fatality. I think this is something we could discuss further. What are the factors? And part of it is testing. Lagos has the highest number of testing. A state such as Yobe has no testing facility within the state. Most patients present very late. They come when they are very ill. And at the end of the day, only those who are very ill get tested. Therefore, it means that the case fatality is likely to be very high. Clinical data from Nigeria has been very limited, but I had access to this preliminary data of 50 patients who died. And what was interesting was that the age ranged from 14 to 82 years, median age was 55, 70% were males, but most interesting was that 58% were less than 60 years. This is clearly different from what has been reported across the world. So despite the young age in Africa, young people are dying from COVID-19. How has it impacted the healthcare system? Outpatient clinic services are very limited. Elective surgeries are almost at a standstill. Most healthcare resources have been diverted to COVID-19. And this is a challenge because this has led to increase in mortality for other diseases. Oxygen we didn't have enough oxygen, and now most of the oxygen that is available is diverted for caring for COVID-19 patients. Therefore, we're having increased mortality. So COVID-19 may not be killing people directly, but indirectly, a lot of people are dying. One, as a result of lack of care, fear, poor testing. People come, they are ill, you don't have a test, and you can't get the results back quickly. They are left isolated. So there are issues that are leading to this. TB services, I must point out, is affected. Patients are not presenting at the TB treatment centers. Diagnosis, case identification has reduced remarkably. Lagos had a 24% case identification, and that has reduced. Other aspects of care, immunization, cancer treatment is also affected. Healthcare workers are becoming infected. And in a country where we had limited number of healthcare workers, the impact could be huge. We have barriers to addressing the pandemic. I've talked about testing. Testing is a barrier. You can't get testing readily. Self-isolation. People are expected to self-isolate at home when there's poor housing, like in other sub-Saharan African countries. Treatment centers are becoming overwhelmed. Currently, people are moved from one treatment center to another, trying to find a space, particularly in a hotspot such as Lagos. Oxygen and oxygen delivery is a challenge. When it comes to ICU bed space, very limited. This afternoon, somebody is frantically looking for an ICU bed space for a patient. We have issues with personnel. In some treatment centers, you have two doctors to 70 patients. That could be challenging. Adequate PPEs for healthcare workers. And I'm sure we also, this paper that came out on June 1st from the Lancet that clearly showed that N95 masks were more protective in the healthcare setting compared to surgical masks. Therefore, providing adequate PPEs for healthcare workers is likely to be a challenge. The economic costs, one test costs the government a lot of money. And in a country such as this is also a challenge. We have the vulnerable population, people who have pre-existing health conditions, TB, HIV, that is a problem. Misinformation and myths are also problems. But in any pandemic, there are opportunities. We have opportunities to strengthen our healthcare system. We have opportunity to leverage on the interest in COVID-19 at this time from other sectors to be able to build the healthcare system. We have opportunities for education and training, particularly training for critical care. We need to strengthen our telemedicine capabilities, which can come in useful even after the pandemic, particularly in hard-to-reach areas. This is an opportunity for innovation in technology, developing PPEs, education, many opportunities. And above all, this is an opportunity for us to recognize that we're all in this together, so that leaders, stakeholders, and policymakers, so that we can all come together to address the inequalities that exist in our society. Thank you.
David, you're muted.
Right, okay. Thank you, Dr. Ohjo. I'd like to introduce our next speaker, who's Professor Refilwe Masekela, who is a pediatric pulmonologist and head of the Department of Pediatrics and Childhood Health at the University of KwaZulu-Natal. Dr. Ohjo. Oh, sorry, it wasn't, sorry, sorry, I meant to welcome Dr. Masekela.
Thank you, David. Thanks for that kind introduction. I've been tasked to give a perspective of SARS-CoV-2 in South Africa. So that's what I'll be talking about this afternoon in the US and this evening in Africa. Right. So I thought I'd talk a little bit about the modeling data that we had prior to us hitting the pandemic in Africa. And I'll tell you a little bit about where we are in terms of COVID-19 in South Africa, and we'll talk a little bit about some challenges and opportunities. So the African Center of Strategic Studies decided to do some modeling and to see what impact COVID-19 would have in sub-Saharan Africa. And they used a number of factors, which included, of course, international exposure in terms of imported cases, looking at the strength of the health system, urban density, issues around the population age and conflict, and the transparency of the government, etc. So what did they find? They came up with the top 10 countries in Africa that they thought would be impacted the most. And if you look at the countries on the left-hand side, you can see the ones that are highlighted in red are the ones that actually did make it to the top of the list if we look at the current data from Africa. And those countries would be Nigeria, Cameroon, Egypt, and Sudan. South Africa was number 28 on that predicted list. But as of June 1, you can see that South Africa is actually leading Africa in terms of the number of cases. As of today, there's over 37,000 cases of COVID-19 in South Africa, and we've done just over 750,000 tests. But interestingly, the other 4 countries that were highlighted did make it to the top of the top 10 list of countries that are impacted in Africa. But also, again, to just highlight that there's countries where the number of tests, all those that have question marks where we actually don't know what the testing numbers are in sub-Saharan Africa. So that's still a challenge. Now, if we look at the population dynamics in South Africa, we have quite a young population as the rest of sub-Saharan Africa, We are one of the countries with the highest burden of TB and HIV in Africa, with over 500 people per 100,000 for TB and the highest HIV infection rate in the world. Although South Africa is a middle-income country, we still have a very unequal society with high levels of poverty, so a lot of malnutrition, and a number of children actually rely on the school nutrition program in order for them to access food. And we also have some differences in terms of the public and private healthcare system, with the most funding going into the private healthcare system. Now, just to show you that in terms of COVID-19 cases, if you look at the rest of Africa, South Africa has the highest burden. Now, what about testing capacity? I think Ohjo has shown some data from Nigeria. This is also data from our world data showing that in South Africa, this is basically from our stats, the positivity rate from all the screened people in the population is about it stands at about 4.7% positivity. Now, we initially started, the first case in South Africa was on 2nd of March, and it was an imported case from Italy. And since then, there were a number of, the government took up a strategy of doing a population-wide screening using a number of healthcare workers to screen people in the population, and that's why we initially had a huge increase in numbers in terms of the testing for people for COVID. Now, there has been some modeling data which was done to show us whether whether we would have what number of active cases we'd have in the population, to look at the hospital capacity, ICU beds, and obviously the cumulative deaths. The pink is actually the worst case scenario, with the purple being the best case scenario. And if you look at the data, it goes from June up to November of 2020. And one of the worrying things is in South Africa, we think that by mid-July, we would have hit the number of the ICU bed capacity. So one of the strategies that the government has taken is to create a huge number of field hospitals in the major centers in the country where there are huge numbers of cases. And I'll show you the data in a little bit. So really, this is just to show the trends in terms of the cases in South Africa. We had our hard lockdown on the 17th of March. That's when the cases were really flattening out, and there has been, we still are in a lockdown, but there's been a number of easing measures that have taken place, and this has resulted in a steady rise of cases in the population. Although we're still under a relative lockdown, the numbers are slowly increasing in the population. So where is the epicenter of COVID-19 in South Africa? When the first modeling data was being done, Gauteng, which is like the New York of South Africa, is the most highly populated city in South Africa. They had thought that Gauteng would be the way we'd have the most cases, but it just happens that the Western Cape has actually been where we've been hardest hit, with the majority, over 65% of the cases in South Africa are actually at the moment in the Western Cape. Now, if you look at the age distribution and the male-female distribution, it's quite interesting. In South Africa, we have a slightly different scenario where females are more affected than males. And I think, as with other countries, the pediatric age group is not as affected. The number of cases in the pediatric age group is just below 6%. With over 650 deaths that we've had so far, we've only had 3 children dying. One who was an extremely premature baby, probably died from premature related diseases, and 2 other children who had comorbidities. So I just thought I would compare, looking at South Africa with the number of deaths. Of course, South Africa has more cases, but compared to Nigeria and Kenya, you can see that we're sort of following each other in terms of trends. So I think with regards to challenges in South Africa, the reason why there's been this huge drive to create these field hospitals is because in South Africa, the majority of the population is very poor. People live in informal households. It's impossible to have any kind of reasonable social distancing. So when cases are identified, they have to be taken for isolation in these isolation facilities in these field hospitals. We have a huge informal economy, which people depend on. And with the hard lockdown, a number of people actually lost their work. And although South Africa has had some mitigation strategies in terms of funding for impoverished people in the population, I think this has still not been enough. And that also has created a number of challenges in terms of people being able to work and provide for themselves, and of course then maintain strict hygienic measures and the social distancing that is still required to limit the numbers. Now, although we may be testing quite a lot of people in the population, at the moment we're doing an average of about 18,000 tests per day. We should be doing almost double of that on a daily rate. There's great limitation, of course, because I think testing kits is becoming a worldwide problem. Just getting the testing kits available in the country is posing a challenge. So the strategy has now moved away from community-wide testing to more focused, targeted testing of healthcare workers, as well as people who are ill in hospital, to try to make sure that the turnaround times are still reasonable for those people at highest risk. Now, again, one of the biggest challenges is we are not anywhere near our peak of the epidemic in South Africa. There's moves to try to get children back to school because of the socioeconomic challenges we have in the country. People don't have access to mobile technology to be able to do remote learning. And as I said, a lot of children actually rely on the school nutrition programs. So getting children back to school is a necessity, although we are not at a plateau yet, but children have to go back to school, and it's posing a big challenge in terms of how to do that safely in a context where some of the schools don't have any access to water or good ablution facilities. So what have the opportunities been for South Africa? I think one of the things is there's been some improvement in terms of healthcare facilities. A number of hospitals that hadn't been completed were completed, which is good. There's been a huge increase in staffing numbers. In many of the hospitals, clinics, the staffing levels have been boosted to be able to cope with the surge. A number of schools as well as communities, because of the prevention measures that are required to address COVID-19, have now been provided with clean running water, which they didn't have in the past. So I think although it's a terrible thing to have this condition, but it has actually raised some opportunities to solve some of the socioeconomic challenges that we have at the moment. Now, of course, we in Africa, we have a lot of different dynamics when compared to Europe, US, and the East. We have now opportunity to see what the impact of COVID-19 will be in a setting where there's many other challenges, despite access to oxygen, ICU facilities, but having a young population with other comorbidities, to see what the impact will be in that context. And I'd just like to acknowledge Christina, the team from ATS Global Health, and Mobile from the PAT side for organizing this fantastic webinar. Thank you very much for your attention.
Thank you very much, Professor Masekela, and beautiful presentation. Thank you. I would now like to welcome our last speaker, Professor Gabriel Lockhart. Professor Lockhart is an instructor of medicine at the Division of Pulmonology, Critical Care and Sleep Medicine at the National Jewish Health in Denver, USA. So, Professor Lockhart, please go ahead.
Okay. Thank you for the introduction. Happy to be here. Given the limited time, I'm going to get right to it. No disclosures. So kind of looking at the state of where we are as the United States, obviously we're a little different with our population being at 328 million. But just kind of where we started from. On the left most graphs here, I have this confirmed case trajectory by log scale. I have this death case trajectory by log scale, both with day one on the x-axis being correlating with the first 100 confirmed cases. And then I have this death case trajectory with the on the y-axis being the 3-day averages of deaths, and the x-axis being the cumulative deaths. These are comparing U.S. versus China, Italy, South Korea, UK, and Canada, with this data being current through May 29th. So as you can see, initially we had our first confirmed case in January 21st. I want you to notice that, or remember that date, because that was a day after South Korea announced their first case. We eventually got to our 100th confirmed case on March 3rd, so that corresponds with day one. And then just 8 days later, we went up to 1,000. 8 days after that, we went up to 10,000. And in between that, our president declared a national emergency, and subsequently more strict social distancing, shelter-in-place measures were rolled out, which was on a state-by-state basis, how strict. And then, eventually by day 25, a little bit beforehand, we had surpassed the world in terms of how many cases. Went up to 100,000 cases by day 25. Went up to 2,000 cases just 5 days after that. By day 40, we had passed Italy as the country with the most deaths. There was such a economic burden as we've all faced. There's been a lot of political uproar about whether we should be starting to reopen some businesses, even just shortly after surpassing Italy as our top as the top deaths. Businesses were wanting to reopen by day 53. Our unemployment rate hit the highest since the Great Depression, with 20.5 million jobs lost in April. So there's a lot of pressure from that perspective. But then we get up to, I want you to notice back here around our about day 15 or so, there's this uptick of cases, and this is kind of where we separate from South Korea. Remember, South Korea announced their first case the day before us. They took different measures than we took, and they had this nice flattening of the curve there, whereas we had an uptick and then proceeded to really have a ton of cases. So at this point, we're about 108,000 deaths with about 1.9 million cases. But when you look at per capita, we're ranked 9th in the world in terms of deaths, and 10th if you look at case fatality rates at 5.8%, which of course is a flawed process. And then if you compare our deaths to other U.S. tragedies, you can combine several wars: Vietnam War, Korean War, Afghanistan War. All these things combined, mass shootings, just barely surpass what we've suffered so far from coronavirus. And we're probably going to overtake the amount of losses we suffered in World War I pretty shortly. We're up to about 108,000 now. So just quickly, I won't belabor points as we're short on time. This is pretty typical for highest risk populations: older age, male more than female, nursing home residents, long-term care facility residents, lower socioeconomic status, which I'll go into more later. And then decreasing order, this is how our comorbidities rank in terms of who gets hospitalized. Typical symptoms, what you see, I won't belabor the point. But there's a question about testing, where if you look at where South Korea was able to separate from us, they were able to test as many people as they could, and that was key, was case identification and isolation. But obviously we know that getting the amount of testing is difficult for a variety of reasons. in the setting of limited testing, the CDC put out these guidelines about who to test in what order, with the priority one being to reduce the risk of nosocomial infections and maintain our healthcare system. Our hospitalized patients and healthcare workers were prioritized. The second priority being a way to ensure those at the highest risk of complications of infection were rapidly identified and triage, so those at the high risk population. And then in order to decrease community spread amongst where it's higher COVID-19 hospitalizations, that's kind of where priority 3 was pointed towards. And then, of course, how we handled it, we increased our ICU bed capacity, went 3 to 4 times. I had opportunity to volunteer in New York a couple of different stints. I was able to see the epicenter where we hit the hardest, and they were able to increase their ICU beds by about 4-fold. They separated the COVID patients early on from non-COVID patients. We had Elon Musk was able to donate some old CPAP machines that they could MacGyver jig into something that was able to at least provide some sort of ventilator support if it was needed. And that was their last case scenario. And then something that was underappreciated initially was the amount of disproportionate AKIs, some kidney injuries where dialysis was needed. And we actually had quite a bit of decisions to make about prioritizing who's going to get dialysis and who's not, because we're running short on that. Of course, we went more towards a waiting to intubate, less aggressive approach with intubating, tolerating that happy hypoxia, utilizing heated high flow more than non-invasives, using those patients who could tolerate, who didn't look like they had a huge work of breathing, and having them do awake proning. Vigilant ARDS-net care, that's so key. Even before this, we had studies that show about 50% of providers and ICUs didn't do ARDS-net, even though the data has been out there for so long. But that's vigilant ARDS-net care was very key. And then I'll just proceed to the therapeutics. We see that the initiatives are actually chloroquine and any macrolide use. It was thrown at everybody initially, didn't see much benefit, and then studies showed that it really was increased deaths due to increased ventricular arrhythmias. This steroids was controversial. It seemed like the population of healthcare workers in New York were very pro-steroids, and majority of the patients in New York were getting steroids, whereas the rest of the country was less pro-steroids. And the only kind of guidance we have on that is maybe consider it an ARDS, otherwise don't consider steroids from NIH. A lot of clotting issues. Most people were just empirically putting patients on full dose low molecular weight heparin, but we don't know. We know that there's increased rates of clotting happening, but we don't know that if it's really necessary to do the full dose. And our NIH guidelines would say just to be vigilant about prophylaxis of appropriate patients. Remdesivir, not much of a mortality benefit, but perhaps there's a decrease in time to improvement from 15 days to 11 days per that recent paper came out a couple of weeks ago. Convalescent plasma, we're using anti-IL-6. There's plus minus, I haven't seen much benefit with that. And then we've got a couple of studies going on with these anti-GM-CSF. But really key to have a central drug coordinator, a trial coordinator if available. And then quickly about the, as we all know, there's 2 factors that are going to be the crux for all of us to move forward to a semblance of normalcy. And one being an effective vaccine, and the other being accurate, reliable, inexpensive, readily available testing. Both factors, of course, are easier said than done. But in 2018, the U.S. proposed a plan for a flu vaccine distribution in the event of a pandemic, as response to a prior H1N1 experience. And this is something that may be something that we look into the future once we're able to get a vaccine, is prioritizing by different tier groups. Tier 1 being by occupation high risk populations. There's different exposure groups and you can see by how much population relative to the whole population of the United States that we have in each tier, with occupational groups meaning healthcare workers and frontline workers and EMS and law enforcement, high-risk population being pregnant women and infant and toddlers, and it kind of just goes stepwise from there. But something I wanted to touch upon, I'm sorry I had this up. is this, the U.S. has been in the news a lot lately with a lot of racial disparities and rioting. In the breakdown of COVID cases in New York City, again, the epicenter of where America suffered the harshest consequences. This is based on zip codes. With these figures highlighting the socioeconomic class and racial inequities in the pandemic. And this data was through April 21st. You can see that in this far right, this is the caseload with the darker purple zip code areas of New York City being where the case rate of COVID was hit the hardest. And you can see where it correlates to the median income in reverse. So the lighter areas or the poorer areas with less income, and the darker areas with higher income. And you can see that there's an inverse in terms of caseload, where the poorer areas were more harshly affected, the richer areas less affected. And this continues on when you look at where the people of color more reside in. It continues on when you look at percentage of people who live under the poverty line, where the more densely populated areas are, and in areas where they lack health insurance. And so, why is this the case? You can really, this has been a long-standing issue in the U.S. It's only been accentuated by the pandemic and placing a spotlight on this disparity. And the living conditions where, again, densely populated areas, there's racial segregation that tends to occur systemically from decades ago. These multi-generational households and overrepresentation of people of color in jails. Their working circumstances where these people are generally in more essential industries, service industry, where they don't have the ability to take paid sick leave. They kind of have to tough through it. And they have higher financial implications of missing work for their household. And they typically have higher prevalence of chronic conditions, higher percentage, again, where they're uninsured. And there's going to be a lot of distrust, as you can see what's going on in our country right now, where there's this ingrained distrust amongst some healthcare between the healthcare system and people of color. And so, there's a lot of things that you can look into. I don't have time to go through everything in terms of what can be done to improve this, but this is something that we're recognizing, and obviously there's a lot more improvement that needs to happen from this, but I hope it does. Some things that quickly, the biggest pitfalls from the U.S. and recall that South Korea bit where the first case was the day before the U.S. They mounted a robust public health response. We tested 3 times as many citizens per capita as the U.S. And then 4+ months later, it's kept its case to about 10,000, where U.S. cases are now close to about 1.9 million. So delay in our preparation or leadership from the top down. Wasn't really taking this as serious as we should have. There's been a delay in developing our testing. Our first round of testing hit snags, and just a delay in social distancing measures, and then less strictly enforced social distancing measures. So a lot of things to pick and choose from, but quite a bit from the top down that kind of led to our situation in the U.S. Thank you.
Dave, you're on mute.
Okay, sorry for being on mute. And we thank you, Professor Lockhart, and really to all of our presenters for fantastic and provocative talks. And I'd like to turn things over now to Professor Von Ziel-Schmidt to lead the Q&A discussion portion of this webinar. And thanks to the audience for many fantastic questions.
Thanks, David, and yeah, thanks to everyone else. It is really a challenge that we're all facing, and I think we're all in different spaces of this particular pandemic. I have just come off service this past week in the Thoracic intensive care unit. We started with 3 patients with COVID a few weeks back. We now have 37 ventilated patients with COVID currently. We're not going to run out of ventilators, we're going to run out of nursing staff. And so I think the biggest challenge we're going to find, I think, across the continent is is not necessarily equipment. It will be, because oxygen is a major challenge for this disease, but I think staffing is going to be a major challenge. And so, you know, in the sort of flagship hospital of the country, we can't expand our ICU care much more at the moment because we lack nursing staff to look after these patients. So I think we face a multitude of challenges across the continent, which is going to be different. And I think the other sort of editorial comment, just before I get into the questions, is that we're, I think, all in very early stages of the epidemic. And we're going to have some phenomenal statisticians to be adjusting for confounders. You know, why are we seeing more African women in Cape Town affected, or more African males in different parts of the continent? I think it's going to be a lot to do with who we're testing, how we're testing, where we're testing, when we're testing, which is seriously going to confound our epidemiology, because those that have access are going to be tested, and those that don't have access won't be tested and aren't going to get into the statistics. There are a few questions that have popped up. I'm just going to answer one of them very quickly, the issue about peritoneal dialysis. Certainly at Groote Schuur Hospital, we have access to peritoneal dialysis and normal dialysis. And peritoneal dialysis, particularly in COVID, is not something that we are looking at. It's particularly labor intensive. It's also very unhelpful if you're trying to prone patients, and having extra fluid in your abdomen also doesn't help your pulmonary dynamics. Dialysis is a very, very, very scarce resource across the African continent. And I think to follow on your last comment, Gabriel, that Africa has to prevent patients from getting sick. By the time our African population needs intensive care, I think we've lost the boat. We have to focus on prevention of infection, because we just do not, as a continent, have anywhere near the resources, no matter what we do, to be able to face anything near like New York did. Just the simple issue of oxygen is something that, you know, a New York hospital might take for granted, but oxygen similarly is a challenging supply. So maybe I can just kick off as the questions come in, just to ask each of the panelists a specific question. And for Luis, can I ask you, from a Kenyan point of view, are you seeing much in the way of immigration, people crossing the borders from your surrounding countries to get healthcare? Maybe those that are in close proximity, Tanzanians, seeing that the Kenyan healthcare system is better than theirs, that they are crossing the borders, or is that not something that's being seen?
So we have known for a long time that certain border counties offer a lot of healthcare to the neighboring countries. So Tanzania, for example, there's certain countries along the border that probably serve more Tanzanians than Kenyans. Somalia is another area that's of particular concern because of a very weak healthcare system, and a lot of them would cross the border into Kenya. So currently, we're still having that challenge, but most of the border testing has sort of targeted truck drivers, because you want to really just traverse the country, going into the inland countries. So a lot of the testing has targeted the truck drivers, but I think as we see more cases, it's going to target everybody presenting with severe respiratory illness or with some respiratory illness into the health facilities along the borders. And that's when we'll be able to tell what proportion is actually crossing over just to look for healthcare related to COVID. But there are those who do that because of the mental health.
Okay. Great, thanks. Ohjo, can I ask you a question? Nigeria is one of the countries globally that has the biggest population. And if you look at Brazil and the US in terms of the number of cases that we're seeing, I can only assume that the Nigerian pulmonologists must be getting a little bit nervous about repeating a Brazil, Italy, or Spain in Nigeria. Do you have any sense of whether the disease, you showed us the numbers, particularly in Lagos, whether that's a true reflection of the current urban-rural sort of gradient of true cases, or is that just a function of testing from an urban-rural gradient, and actually many cases are going undocumented?
Yes, not just the urban-rural gradient, even the numbers in Lagos, we think is an underestimation. A lot of patients die before getting tests. So, and these cases are not being counted. A lot of people are dying at home because there's fear of going to the hospital. You're going to get infected when you get to the hospital. So the numbers really, I think, is an underestimate of the case. And then in the areas where you have very low number of cases, we've also had issues of several hundred deaths in a week, and the cause is unknown in certain parts of the country. So the issue is, we think what we have is just the tip of the iceberg. An issue of testing, an issue of also documenting. In the US and in China, they were counting cases that looks like COVID. Here, we are not counting cases that look like COVID. We are counting those who come out to be positive. So that's a challenge. So I agree with you that we think this is just the beginning of the epidemic for us.
Rafilda, can I ask you a question, both as a pediatrician and as a mother? The issue of children. Now, I mean, when it came out, we looked and saw that children pretty much never got COVID. Now, clearly that can't be true because infectious diseases are really across the board in terms of the age spectrum. But do you think, I mean, what is it about children that we're not seeing it? And are our children who are going back to school safe, in a sense, given the data we have about the lack of severe pediatric disease?
Thanks, Richard. Well, I think there's been a number of suppositions why the burden in the pediatric age group is definitely lower than in adults. Some of it related to the immaturity of the
You're
ACE2
breaking.
Is that better? Can you hear me now? So some of it is thought to be related to the immaturity of the ACE2 receptor system in children. Secondly, we know that children have already got a viral soup in the upper airways if you test them, and perhaps there's a little bit of competition and a more robust immune system in children in terms of fighting off the virus, which is quite unusual compared to all the other viruses that we know, because usually children are the ones that usually bear the burden of these viral infections. So it's very encouraging that children now for once seem to be more protected than adults. And around the issue of going back to school, I think in our South African context, because of the socioeconomic dynamics, it's a very, if you look at the risk-benefit ratio of children going back to school, the majority of children, more than 80% of the population, come from very poor households. They have no access to education. I think social distancing in a shack is really a dream. So they don't even have any kind of social distancing. I show you those photographs, they play in the streets anyway. So for those children to go back to school, I think actually if you're looking at the risk of them going back to school, they'll probably be safer because in the school they'll be given a mask, there'll be sanitizers, and there will be some sort of social distancing as well as getting a meal at school. So I think for children who actually are making such a small proportion of the cases, it's actually disadvantaging them to not go to school at the moment. If we're really looking at the benefits and the risk in our population, I think kids should go back to school because it will cause more harm to keep them away from a very structured environment where they're learning to keep them in the streets for months at a time, having a mitigation strategy which is not really a true reflection of what's happening in the population. So I think it's safer for children to go back to school.
And Richard, if I can just intervene for a minute. I'm a pediatric pulmonologist, and I'm kind of intrigued with what's going on in Nigeria. So, Professor Ohjo, I mean, it seems like there's a lot of kids are affected with the COVID in Nigeria versus us here that we don't have that many. Did they have, like, did you study them to see if they have any underlying conditions that led to that? Or, you know, if you can elaborate, that was a question as well from the audience.
I wouldn't say a lot of kids are affected.
You're muted.
They are, no,
You're not muted.
Can you hear me now?
Okay. Yeah.
Can you hear me now?
Mm-hmm.
All right. Not really. We can't say a lot of kids are affected. The data I showed was the data for mortality, and the youngest age was 14. We've had some kids, but in families that have come in, and the children were mainly asymptomatic. The child who died in the data I showed was actually a child who had some comorbid condition, but generally the children have also been few, and their cases have been mild and asymptomatic.
Oh, okay. Thank you.
I mean, certainly in our experience of Cape Town, where we, as Rafiwe pointed out, have the epicenter in South Africa, our intensive care population are in their 40s. We take anyone over the age of 13, and we haven't had any young adolescents yet. So yeah, I mean, it's heartening to know that the epidemic seems to be dodging children at this point. Gabriel, can I ask you one specific question from myself, and then one that's come from the questions? And it's going to be a difficult question for you because of your US context, but how do you convince people that this is something that's important and actually real, and they need to behave appropriately? And then following on from that, a question comes from Bertrand from Cameroon in terms of the factors and elements which determine the peak period of the COVID pandemic, which obviously follows on from my first question of how do you tell people or convince people that this is something that's important?
That is a question that we still struggle with today in the U.S. There's a lot of conspiracy theory, misinformation that's put out in social media, where people are just not believing, if they're not physically seeing it happen around them, if they're not in New York or these high population cities, if they're more in a rural area or in smaller towns, they don't have as much issues with COVID. There are a lot of people who just straight up don't believe it. There's a lot of distrust in our country about the news, media, and so forth. So how to affect that population? I mean, really, it's just a lot of discourse, a lot of, I try to have reputable sources who are able to provide, public speaking through, forums like this, or forums that can reach massive people. So unfortunately, sometimes that means social media as well. But trying to show them, firsthand experiences. Like I was able to document my experience in New York. I wrote a journal about it that was published in our news in the United States, and people were able to kind of really see from my perspective, and I was able to relay it to this perspective that could be understood by lay people, what's going on and how serious this really is. So just trying to give that firsthand account, and you try to provide the data you can that shows why it's necessary to do the social distancing that we ask for. But a lot of people still have a lot of distrust depending on their background. And in answer to your second question, there's a lot of things that go into what's going to be affecting. So like I mentioned towards the end of my talk, that things like density population, this is all going to be country dependent, and even within a country it's going to be state or city dependent. But country or density population, the epidemiology of the people that live there, what underlying comorbidities do they have? Obviously in America we have a higher rate of obesity and hypertension and coronary artery disease. And so that tends to be a higher population of our patients. And so depending on these factors is what's going to determine and how well people are social distancing. And we have data looking at the charting cell phones from people in different cities. We saw that was able, that early on they were able to social distance appropriately, but then they really started slacking and we're going out a lot more towards the second half of our social distancing. And we saw fortunately that kind of lined up with the weather getting a little bit warmer, and people were still at least somewhat social distancing, but all these different things kind of correlate to what the peak's going to.
Okay, brilliant. Samia, you wanted to ask a question to one of the panelists.
Yes, it's actually a general question. So what can we learn from early affected countries in using mechanical ventilation in critical patients? And how do we prioritize patients in resource-limited areas?
So something that we did, in Colorado, Denver with National Jewish, and New York did as well, is that we teamed up with our local government and came together with having actual people who are experts in lung, pulmonary and critical care, and providing a kind of an opinion on how we should resource this. And we fortunately, as a nation, we didn't get that bad off of ventilator use. I think New York, there were a few hospitals that came really close or maybe did come short with ventilator use. But for the most part, as a country, that wasn't as big of an issue as it could have been. But we were prepared. We had a statement in place, a plan in place for if it came to that, but how we would decide who gets a ventilator and who doesn't, if we need to. We had an independent team that was not taking care of the patients, that would evaluate each patient from afar and decide if we needed to have more ventilators. They would make the decision, and they would talk it over with the team that's actually taking care of the patient. They wanted to take that burden away from the team physically taking care of the patient, so there's not that bias. So that was very helpful. Again, we never had to enact that, but that was something we had in place. And then, being able to, I think I lost my thought. But yeah, that's, I think having a plan in place in advance is going to be the most beneficial.
Yeah, and that's certainly in the US. How about in Africa? Yeah, right. Sorry, go ahead.
So I mean, it's one of those strange things that I mean, we've had this discussion in our intensive care unit quite often, that rationing is part and parcel of healthcare in Africa. We do it every single day. Every day of my life, I'm making decisions about who gets into ICU and who does not. This is not a new sudden crisis that we have to deal with to decide, do I give a ventilator for a 45-year-old or a 50-year-old or a 60-year-old? This is what we do, pediatrics, adults, surgery. This is part and parcel. The challenge, I think, and certainly we've seen, is that you have two 45-year-olds, one with diabetes and one with hypertension, both needing your last ventilator bed. Now you have to make a decision between the two. And so that's where the challenges come. But certainly rationing, this is what we do because we don't have resources. And it's just a slightly different population. So it is a challenge. Mechanical ventilation is a very rare resource within the African continent because it requires a tertiary hospital, it requires electricity, it requires oxygen, it requires nursing staff and critical care specialists. So it's not a common occurrence. And simply, as I said, providing ventilators, dropping off 20,000 ventilators in the middle of an African country isn't going to solve your problem because you need the staff to support it. And so I really think, and I think we've heard it from many of the panelists, by the time you get to ICU, we as Africa have missed the boat. We need to prevent it far, far before that. Unfortunately, we don't have a vaccine at this particular point, and we're going to have to be fighting with the rest of the world when the vaccine comes through for the African continent not to stand third or fourth in line for vaccination. So I think we face multiple challenges across the continent in different guises, I think, in different countries, and certainly Cape Town, Durban, Johannesburg are a very different ballpark to Nairobi or Lagos. We all have our different challenges, and even chatting to Stephen Gordon recently in Malawi, even just the simple supply of oxygen to, plugging your nasal prongs into the wall is not something that occurs in many places. So I think we have challenges. I think this has been a very helpful webinar, and I personally am very grateful to ATS and PATS for providing this opportunity to have the discussion. And in a sense, I think Africa is in a better place than the US and the rest of the world is, because we get to learn from the mistakes of those that have gone before us and realize what does and doesn't work. There aren't any more questions coming through on the chat, and so I'm just going to hand over to Samia to summarize and then close this very informative session off for us.
Thank you very much, Richard. It's been really a wonderful session, excuse me. So on behalf of all participants, the ATS International Health Committee and the Pan-African Thoracic Society, sorry, let me turn on my video, okay. I would like to thank all of our presenters for their perspectives, recommendations, and strategies. We really appreciate it, and it was very, very informative. A quick reminder to our participants, please complete the evaluation so that we can identify future topics and continue to improve this series. I invite all participants to join us for future presentations of this webinar series, and I wish you all health and safety during the COVID pandemic, and my thoughts are all with everybody, especially our African American brothers and sisters in the US, and I hope things settle down for everybody. So thank you very much, and really it was wonderful presentations. We applaud all of you guys. Thank you.
Thanks, everybody.
All right.